you tell your neurologist when he upsets you? You say, "You, sir, are like myelin. You get on my nerves." Hello, everybody. It's Ryan here. I hope you and your family are well. Today, we're discussing, myasthenia gravis. Here's an outline of our talk. We're going to be discussing a clinical case and then looking at myasthenia gravis and breaking it down in terms of etiology, patient presentation, differential diagnosis, diagnostic evaluation, treatment and management, prognosis and complications, and of course, we're ending off with the biblical scripture. God bless you. Thanks for joining me. Guys, let's get stuck into the case. Today, we have a 34-year-old woman who is seeing you for a complaint of weakness for the last month. She notes this to be particularly worse in the late afternoon and evening, towards the end of the day. So initially, she attributed the weakness to stress from her job, but she feels that the weakness is worsening despite taking several days off work. She is also noticing some occasional double vision, and her husband has noticed that her voice sounds weak. The patient denies pain. On physical examination, you notice the appearance of mild ptosis and a nasal breath tone to her voice. Which of the following tests would be most sensitive and specific for making a diagnosis in the patient? Is it A, acetylcholine receptor antibodies, B, the edrophonium test, C is muscle-specific kinase antibodies, is it D, repetitive nerve stimulation, or E, voltage-gated calcium channel antibodies? Nice to ask. So myasthenia gravis, everybody, is an autoimmune disease caused by the development of antibodies against the acetylcholine receptors at the neuromuscular junction that inhibits muscle membrane depolarization. It results in interference of neuromuscular transmission, and hence it leads to muscular weakness. Now, it occurs primarily among young women, but also older men, but can occur basically at any age, right? Let's look at the etiology, epidemiology, and risk factors associated with it. So the pathogenesis is thought to begin in the thymic tissue, which provides an area for autoantibody production among susceptible patients. There is a somewhat about 20% concurrence with autoimmune hypothyroidism, which keeps company with myasthenia gravis, suggesting a more generalized autoimmune disorder. By and large, myasthenia gravis is associated with thymic hyperplasia in upwards of 80% of cases, thymoma in around 15% of cases, of which 30% are malignant, so watch out for that. Thyrotoxicosis, rheumatoid arthritis, and lupus, systemic lupus erythematosus, the wolf. Awoo! Myasthenic crisis are associated with infections and may result in respiratory muscle weakness, which necessitates intubation. Alrighty, so neonatal myasthenia occurs in about 12% of pregnancies to women who are myasthenic via placental transfer of the anti-acetylcholine receptor antibodies. All right, it can be triggered by illness, stress, thyroid dysfunction, pregnancy, and a whole host of drugs, which we'll be addressing. Familial occurrence is rare, but first-degree relatives do have a higher incidence of other autoimmune diseases as well. This is taken from Harrison's, guys. It just shows us in like a bird's eye view, myasthenia gravis. Let's have a look at what they say. On history, you want to elicit history of diplopia, ptosis, dysarthria, dysphagia, dyspnea, right? Mainly proximal involvement, weakness in a characteristic distribution affecting the proximal limbs, the neck extensors, and generalized. And you have the key word in myasthenia gravis is fatigability, guys. Fluctuation and fatigability, the two F's. It's worse with repetitive activity and improved by a period of rest. And there could be an effect of previous treatments. On physical examination, you have to evaluate for ptosis at rest and following 1 minute of exercise. Check for extraocular muscles and subjective diplopia, orbicularis oculi and oris strength, jaw opening and closure. Assess muscle strength in the neck and extremities, because this hits your proximal musculature first and foremost. Weakness following repeated shoulder abduction, right? So ask them to hold the shoulders out for a long time, and eventually they become fatigable and weak. Vital capacity measurement, very important if you're considering that the patient may need intrathecal intubation. Absence of other neurological signs. Guys, in terms of laboratory testing, the way to go is the anti-acetylcholinesterase or anti-acetylcholine receptor radioimmunoassay. 85% is positive in generalized myasthenia gravis, 50% in ocular myasthenia. Definitive diagnosis is made if these are positive. A negative result does not exclude myasthenia gravis. 40% of acetylcholine receptor antibody negative patients with generalized myasthenia gravis have anti MuSK. Now, MuSK stands for muscle-specific kinase antibody, and 2% have LRP, which stands for lipoprotein receptor-related protein 4. Repetitive nerve stimulation as well, a decrement of more than 10% at 3 Hz, probably points to myasthenia being the diagnosis. Single fiber EMG with blocking and jitter, normal fiber density is confirmatory but not specific. Edrophonium test, edrophonium chloride, 2 milligrams, then 8 milligrams IV, highly probable diagnosis if unequivocally positive. Right, ice pack testing to look for improvement in ptosis is very sensitive. For ocular or cranial myasthenia, you want to exclude intracranial lesions by CT or MRI. Guys, this is looking at the normal neuromuscular junction now. All right, and this is illustration of what happens normally. This is your presynaptic neuron right here, and this is your postsynaptic neuron right here, and this is the neuromuscular junction, okay? And so we have acetylcholine, which is released from vesicles in the presynaptic neuron and docks into your acetylcholine receptor on the postsynaptic neuron, and that, of course, causes a membrane potential to be transmitted across the postsynaptic neuron, and that causes your action potential. All right, but what happens, of course, in myasthenia gravis is that there's going to be a reduced number of acetylcholine receptors. There's these acetylcholine antibodies which dock into the acetylcholine receptors, and that, of course, is going to cause eventually flattened and simplified postsynaptic folds and a widened synaptic space. So there's blocking of neuromuscular transmission, and this basically demonstrates here how we have, let's get my point in there, we have these acetylcholine receptor antibodies which dock into the beautiful acetylcholine receptor on the postsynaptic neuron. Once it does that, it blocks transmission of the action potential across to the postsynaptic neuron, and we also have simplification of these folds on the membrane as well. All right. How do patients present? But we said the key word is fatigable weakness. So ocular and facial muscles, the proximal muscles, are most frequently involved, which will manifest with diplopia, ptosis, dysphagia, drooling, difficulty chewing. 75% of cases are restricted to ocular involvement. Symmetrical limb weakness, respiratory failure due to respiratory muscle weakness. Weakness often fluctuates and is especially prominent following persistent activity. Head lolling, which refers to inability to hold the head up. All right. Symptoms may be subtle as to suggest hysteria, but normal reflexes and cerebellar and sensory function, that's the key. You have normal reflexes, normal cerebellar function, normal sensory function. What's the differential diagnosis for myasthenia? So myasthenia, it can be Guillain-Barré syndrome, botulism, which also affects transmission across the neuromuscular junction, botulism. Lambert-Eaton syndrome, which is autoantibodies not against the postsynaptic acetylcholine receptor. This is antibodies against the presynaptic voltage-gated calcium channel receptor. All right, and then of course you get non-depolarizing muscle relaxants, brainstem stroke, ocular myopathy, thyroid disease, cranial neuropathy, tic paralysis, organophosphate poisoning, very important, amyotrophic lateral sclerosis, and D-penicillamine, which is a temporary reaction. Right. In terms of diagnostics, on history and physical exam, obviously, subacute onset of fluctuating diplopia and ptosis with normal pupillary responses strongly suggest myasthenia. All right. You can do an anticholinergic challenge with edrophonium. Chloride IV will rapidly and temporarily reverse symptoms in most affected individuals, but it's not very specific. It's used to make an initial presumptive diagnosis, or used to distinguish myasthenic crisis in which there's worsening of disease versus cholinergic crisis, which may be due to subtherapeutic drug levels secondary to medications, right? Edrophonium will reverse myasthenic crisis, but will exacerbate cholinergic crisis. Edrophonium will reverse myasthenic crisis, but exacerbate cholinergic crisis. Acetylcholine receptor antibody assay is positive in upwards of 80% of cases, and that's the go-to test, all right? Routine lab testing and CSF analyses are normal. TSH is often abnormal because, myasthenia keeps company with autoimmune diseases of the thyroid. Imaging of the mediastinum to rule out thymoma. Single fiber EMG is the most sensitive electrophysiological test. Repetitive nerve stimulation results in decremental response in motor unit amplitude. Alrighty. So here we're looking at the Harrison's, which is looking at diseases which keep company with myasthenia and recommended lab tests. So associated disorders of the thymus includes thymoma and thymic hyperplasia. All right. Other autoimmune neurological disorders like CIDP and neuromyelitis optica. Other autoimmune conditions like Hashimoto's, Graves, rheumatoid arthritis, lupus, skin disorders, familial history of autoimmune disorder. Disorders or circumstances may exacerbate myasthenia gravis is hyper or hypothyroidism, occult infection, medical treatment for other conditions. That which interferes with therapy is TB, diabetes, peptic ulcer, GI bleeds, renal disease, hypertension, asthma, osteoporosis, obesity. Recommended lab tests or procedures is CT or MRI of the chest, right? Remember, you're all looking for a big old thymus sitting in the mediastinum, right? Test for antinuclear antibodies, rheumatoid factor, thyroid function test, testing for TB, so do your sputum gene expert, do your Mantua test, right? Fasting blood glucose, hemoglobin, A1C, glycated hemoglobin, pulmonary function test, and bone densitometry. Guys, how are we going to treat and manage a patient with myasthenia? So symptomatic treatment with acetylcholinesterase inhibitors like neostigmine, pyridostigmine allows more time for acetylcholine to compete for binding at the active acetylcholine receptor sites, thereby allowing the patient to maintain their strength. Frequent measuring of vital capacity and negative inspiratory force are necessary to evaluate for respiratory muscle function, as intubation may be necessary. Medical therapy also includes corticosteroids. You must start slowly because high initial doses may actually worsen the disease, because we know steroids are associated with myopathy. Intravenous immunoglobulin, immunosuppressive agents, the likes of azathioprine, cyclosporine, methotrexate, mycophenolate for steroid-sparing effect. Plasma pheresis for severe cases. Sorry about the typo there. Severe cases of myasthenic crisis. And thymectomy may be curative, but may take months to become effective. Very important, you want to avoid aminoglycosides and sedative hypnotics, beta blockers, tricyclics, older anticonvulsive medications, procainamide, and other meds that may decrease neuromuscular transmission. This is a beautiful algorithmic approach to myasthenia. We're looking at, if we establish the diagnosis unequivocally, you want to search for associated conditions, and then we basically ascertain, is the patient in crisis? If they are in myasthenic crisis, admit to ICU, treat with any respiratory infections, put the patient into fluids, consider plasmapheresis or intravenous immunoglobulin. Alrighty. But if it's ocular involvement only, you want to do an MRI of the brain, and if positive, you want to reassess. You give anticholinesterase in the way of pyridostigmine. If it's generalized involvement, you give your pyridostigmine, and you also want to evaluate for thymectomy. Right? Indications, of course, are thymoma or generalized myasthenia with anti-acetylcholine receptor antibodies. Evaluate surgical risk and compute your forced vital capacity. Right? And then assess whether you have a good risk or a poor risk. Right? Essentially, if you have a good forced vital capacity, you're going to proceed to thymectomy. If you have poor risk, being a low forced vital capacity, progress through to plasmapheresis or IVIG, and then reassess. Ideally, you want to do thymectomy, evaluate the clinical status. If indicated, go on to immunosuppression, right? So steroids and steroid-sparing agents, all right? That's a beautiful way to look at an approach, diagnostic and treatment approach. Right, so when we're looking at drugs which have interactions with myasthenia, drugs that may exacerbate myasthenia, we have big groups. Antibiotics like aminoglycosides, quinolones, macrolides, watch out. Non-depolarizing muscle relaxants for surgery like pancuronium, vecuronium, actrocurium, right? Pancuronium, sorry, vecuronium. Right, beta-blocking agents like your propranolol, atenolol, local anesthetics, and related agents like procaine, xylocaine, etc. Alrighty, Botox, quinine derivatives, magnesium, penicillamine, which is a copper chelator, right? Or it's a metal chelator, and checkpoint inhibitors. Drugs which have important interactions in myasthenia as well. Don't forget, cyclosporine and tacrolimus have a broad range of drug interactions which may either raise or lower the levels. Azathioprine as well. Avoid allopurinol because a combination may actually result in myelosuppression. Guys, in terms of prognostication and complications, mortality is generally low if the disease is diagnosed early and appropriate supportive measures are instituted. So we cannot underestimate the value of a clinical suspicion of a patient who may have myasthenia, right? It's characterized by remissions and exacerbations of fluctuating weakness, but does not follow a steadily progressive course. Fatigability is the name of the game, guys. When the disease is limited to the ocular muscles for more than 2 years, it rarely extends to other muscles. Patients with a forced vital capacity of less than 1.5 liters usually require prophylactic intubation or at least observation in an intensive care unit. Patients should be admitted if they cannot walk or have signs of respiratory distress. Starting steroids without the direction of neurology is discouraged. Ideally, these patients should be discussed with a neurologist, all right? So coming back to our case, guys, let's just quickly rehash the stem. You got a middle-aged lady who comes to you with a problem of weakness. It's worse towards the end of the day. Initially, she thought it was due to stress, but not so. She's also noticing some double vision, and her husband noticed that her voice sounds weak. On physical examination, you note that she has mild ptosis and a nasal tone to her voice, which is most sensitive and specific for making a diagnosis. And the answer is dum 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 dum. Answer A, acetylcholine receptor antibodies, right? So we said the myasthenia gravis is a relatively common neuromuscular disorder caused by antibody-mediated autoimmune destruction of the acetylcholine receptors at the neuromuscular junction. The most sensitive test for diagnosis is the presence of antibodies against the acetylcholine receptor. These antibodies are present in upwards of 80% of patients with the condition, all right? My friends, I hope that you'll just allow me to take a few moments to speak about the Bible. Today we're talking about the fact that we are made in God's image to do God's work. The book of Genesis chapter 127 says that God created man in his own image. In the image of God he created them. Male and female he created them. Ephesians chapter 2 verse 10, we are his workmanship, created in Christ Jesus for good works, which God prepared beforehand that we should walk in them. The psalmist says that we are fearfully and wonderfully made. The Lord knew us before we were even born, before we were even knit together in our mother's womb, while our hands and feet were still webbed. The Lord knew you. And we are created to do his work. And I pray that we will live to be an extension of his hands and his legs on this earth, doing his will and submitting to him totally for good works. These are my references. You can find me on Instagram, on Facebook, and on TikTok. Just search for Internal Medicine Algorithms and Mnemonics. Thank you so much for joining me, guys. I will see you soon with another helpful topic. We got congestive cardiac failure coming up. Looking forward to that one. All right. Also, acute kidney injury. God bless you. See you soon.